Good evening. My name is Kristen Page Nye, and I serve the American Cancer Society as their Government Relations Director here in Montana. Welcome and thank you for coming to the first ever Montana Pain Initiative Conference. And I just want to thank you all for taking time this Friday evening to be with us. We have a great conference in store for you. Our first speakers tonight were supposed to be Attorney General Mike McGrath and Senator Carolyn Squires, but for those of you who've been watching the legislature in the session, they're not quite ready to come home yet. So both Attorney General Mike McGrath and Senator Carolyn Squires send their regrets. They really did want to be here with you this evening. So why we're here? We're here because the undertreatment of pain is a major public health care problem. And we're here because we feel that there are a lot of tangible public policy barriers that we can identify and help to work to improve. And in 2005, Senator Carolyn Squires from Missoula agreed to carry a Senate Joint Resolution 28, which basically asked the legislature to recognize the creation of a statewide task force to look at the different policy barriers in the state of Montana to good pain management. And the American Cancer Society, through that resolution, did agree to staff that task force, to recruit for that task force, and to help keep that process going. I'm pleased to say that over the last year and a half, that task force has been working very diligently. And tonight, what we're hoping to do is present to you our white paper, our findings of what those barriers are and our recommended solutions to how to accomplish those. What we're trying to accomplish besides presenting the white paper to you this evening is to also get your feedback on that white paper, and towards the end of the evening, you'll also have an opportunity to have an open mic to share your thoughts and your experiences of barriers to sound pain management in Montana and as individuals. The other thing we hope to accomplish between today and tomorrow is networking. We have a great representation of professionals, advocates, those suffering from pain. Please do try to sit next to folks that you don't know, try to share and network, and that's the way that we're going to accomplish a lot of our goals is by talking to one another and figuring out how we're going to move forward. And then the final thing that we're trying to accomplish by the end of tomorrow is to formally launch our Montana Pain Initiative. The task force has been working on assessing pain policy. We're phasing that task force out so that now we can move into working on further assessment, but actually working to overcome some of these barriers. So this conference would not have been able to take place without a really strong and helpful planning committee. And at this time, I'd like the members of that planning team to stand up. And if you could just introduce yourselves to the crowd, I greatly appreciate it. And just keep standing as you. Go ahead, Randy. Why don't you start?
Seacrease.
Go ahead. Keep going. We'll clap at the end.
Catherine Morgan, Shipping Bozeman.
Great. Well, let's thank them for all of their work. I'd also like to take a few moments to thank our sponsors of this conference. On the back of your binder, all of our sponsors are listed for this conference. I really appreciate all of their financial and in-kind support to make this happen as well. It's my privilege to introduce the next speaker, Dr. Randall Seacreast. He's the medical director for the Montana Spine and Pain Center here at St. Patrick's Hospital, who serves on the Montana Pain and Symptom Management Task Force, and as you heard, served on the planning committee. Please join me in welcoming Randall Seacreast.
I'm pinch hitting. Am I pinch hitting for both those people?
Yes.
I think I'll write my mother and tell her I pinch hitted for the Attorney General of Montana. And she'll put that on the refrigerator like she did when I was a kid. As Kristen said, I've been involved with the pain program here at St. Pat's for the last, I guess it's going on 5 years now, 4.5 years ago. It's when we started this program. I come by this very serendipitously. This is not something that I started out to do. This is not something that I set in my sights and said, I'm going to solve this problem, or I'm going to tackle this problem, or I'm going to tilt at this windmill. When we started the Spine Center, we actually started a spine center. We didn't care much about pain. What we cared about was evaluating spine problems and trying to identify those problems and then trying to treat those problems. I'm an orthopedic surgeon by training, so my approach to this was very mechanistic. It was, let's find that problem, let's stamp it out, let's put some metal in there, let's get this problem fixed and then get those people out the door. I was working with 4 neurosurgeons at the time who had the same approach. 6 months into that process, it became obvious to me that that was not the problem. That the problem with our spine center is that there was a huge vacuum out the back door. And that was the back door of people who we sent out of the clinic without a solution. And it became more and more and more obvious to me that we don't always have a solution. And once we don't have that solution, it may be okay for us to send those patients out the door, but there was nowhere for them to go. There was nowhere for those patients to get reasonable pain management or services after they left the spine center. So we pretty much changed our approach to this and began focusing more and more and more on good chronic pain management. Now, I will say that 4 years later, I have to give a lot of credit to this institution, St. Pat's, because I hate to say it, but pain management's not sexy. It's not like cardiothoracic surgery. It's not like neurosurgery. It's not like orthopedic surgery. And it may be news to some of you guys, but it doesn't bring in the same amount of money that those things do. It boils down to hard work, and it boils down to a lot of resources expended for, a relatively small percentage of the patients that we see who require a considerable amount of effort on our part to manage and make their lives better. I don't think you can do this without an organization that really takes a commitment to improving the lives of people and not just simply trying to fix mechanistic problems. And that's why we're where we are today with a fairly robust multidisciplinary pain program, because the St. Pat's system really believed in that vision and supported it every way. So it's been a wild ride for the last 4 years, but I think that I'm beginning to see some of these problems at least coming to light. That brings us to, I guess, probably 9 months ago when Kristen approached us and said, this is what we're doing. We've got this task force. This is what we're trying to do. And we were wondering whether or not you guys would get involved. And I think all of our team said, absolutely. I mean, this is what needs to be done, because there's so many areas that need to be approached. We have to change the policies. We have to influence the politics of pain. At the same time, we have to change the awareness of not only the public, but also the providers that are providing this care. Because my perception, and I think that perception is shared by a lot of people, management of chronic pain in some ways is really a problem of focus and being willing to tackle a problem that sometimes doesn't get the same amount of press that the latest technology gets, or the latest medication, or the latest technology. And it's not something, like I said, that's sexy or something that really creates a lot of superstars. It's just hard work, but it needs to be done. I thought what I would do is to start this two-day event off is to really leave you with some questions that I ask myself every day. And coming to this sort of serendipitously as I did, I had to really look back at my career and look back at the way I dealt with these issues in the other aspects of my career when I was doing other things, and really ask myself, how am I going to rethink this? Because what I'm seeing now doesn't necessarily jive with the dogmatic approach I've always been taught or I've always applied in my own practice. And so I'm going to introduce you to some questions as you go through this conference for the next couple of days. They're questions I ask, and I'm hoping that you'll ask some of these questions. I'm hoping that you'll have some questions of your own, that you sort of start looking at things and asking why. Because I think that's the most important thing that we can do if we're going to change the way that we look at these problems. I think Kristen's right on the money when she says, this is simply the beginning of the next phase. This is not a conference that anybody, I think, is planning to come here and give you the answers and say, well, this is what needs to be done, let's get busy and do it. I think the purpose of this conference is identifying the problems and bringing a group of people together from all over the state and say, this is what we're seeing that we think are problems. These are the barriers we're seeing. These are some of the solutions we think might work. And bringing that level of interest and creating a group of people who are willing to tackle that problem and go to the next step and actually create some sort of an initiative, an organization, whatever it takes to improve the care for these patients. I think the one thing that I've seen over the last 5 years that I've been here at St. Pat's is that there's growth in this area, there's growth in the east, in Billings, and it's becoming obvious that things are changing in some of the communities in Montana. A community like Missoula, which has always seen itself as a community hospital. I mean, our primary mission is to take care of patients. That's changing somewhat. What you're seeing happen in Missoula is collaborations with the University of Montana, a growing health sciences community, a growing biomedical research community. And I think that people in Missoula, and I think I see it happening in Billings as well, probably a little beyond what's happened so far in Missoula, is that people here are beginning to wake up to the notion that we have a responsibility that goes beyond just taking care of patients. Part of the mission of a hospital such as St. Pat's, when it begins to grow and go through that transition to a tertiary referral hospital from a community hospital, is a different commitment. It's a commitment not only to take the best care of patients, but also to take responsibility for educating the region, improving the standard of care in the region, and responsibility to go look and provide an environment so that the rest of the hospitals, the rest of the providers in the area can look to us to raise that standard of care. So I think we're starting to see the St. Pat's system to really take a serious look at that commitment and shoulder that responsibility. So I think things like this, where we try to put situations together where we can foster these conversations and create initiatives to try to improve care are clearly a serious responsibility that we take very seriously. So I think that's to, I guess, elaborate on a little bit what Kristen said. That's what I hope comes out of this conference, is that this is the beginning of a conversation and brings people together of like mind, and we can come back 2 years from now when the next legislature meets and really have some sound successes under our belt and a sound plan to really move forward. So let me leave you with a few questions as we start the night. You know, it's interesting as I listen to people talk and I listen to people who have experience in treating pain, whether it's cancer pain or non-cancer pain, there's something different about pain. And I've questioned what that really is. And the first question I'd like to leave you with is, what is it about pain, and especially the treatment of chronic pain, that polarizes opinion in the medical profession so much? Because I think this is a critical issue. I don't think we get emotionally attached or morally attached to angina or arthritis. But for some reason, we get emotionally attached to pain. I don't know the answer to that. And I think a corollary to that question is, we really need to decide as a profession whether we consider treatment of chronic pain legitimate or illegitimate. Because I don't think we settled that question. I think people really question whether it's the role of the healthcare profession to treat chronic pain. Now, they'll give lip service to it, but ask yourself, when you go to see your doctor and say, I hurt, do you feel like you get a legitimate concern, as if you went and said, I need an artificial knee? I mean, they'll be all over that in a second, but they don't want to talk to you about their pain. Here's a good thing. I heard a lady talk who had been treating cancer pain for 25 years, and her similar question, but she put it a different way. If you see a patient and they say, I'm nauseated, you don't question that. You might step back a step or two, but you don't question it. But the minute someone tells us they're in pain, it's kind of like, that's not as bad as my pain. What are you complaining about? I don't know if this goes back to the Western philosophical tradition of Stoicism or what, but it goes back a long way. And I don't know what that means. Here's another one. And Dr. Johnson's in the room, our chronic pain psychologist, and we're always discussing this with other providers, because somehow we get calls and the first thing they ask us is, do you think that pain's real? You think that patient has real pain? We just sort of look at each other and then look at them and say, what other kind is there? I mean, I don't know. Here's another one that I think I'd like to leave you with, and it's a friend of mine who's a naturopath really sort of woke me up to this notion, because we're constantly talking about education and pain and how to get this across, but what's the difference between living in pain and living with pain? I think we finally decided that what we're trying to do in our multidisciplinary clinic is teach people to live with pain and not in pain. And think about it, there's a profound difference there. I don't know what it is, don't get me wrong, I don't have any answers to these questions, but I got lots of questions. All of this boils down to some of this. I mean, a lot of these are going along the same theme, but I think you ought to ask yourself this. Why do we tend to marginalize or worse, blame the patient when they fail to get better? And I think the corollary to that is really, when will we understand the difference between pain management and pain treatment? And I wanted to say pain cure, but I don't think there is really any such thing. But there's a difference there. I mean, for example, you know, a good example is work comp. Work comp comes and you know, we're treating somebody with chronic pain and they say, are you done yet? Are you ready to get them off the opiates? Are you ready to get them off the narcotics? And it's kind of like, If a person had high blood pressure or high cholesterol, would you ask me, are they done with their blood pressure medications? I doubt it, because I think you got to manage this. And I think more and more we don't realize that, unfortunately, when we sign on to this, we're in for the long haul. This is management. This is a partnership. This is not something that's going to end at some point. I mean, sometimes it does, but there's no guarantees this is going to end. That doesn't mean the patient's to blame. Here's another corollary to that always bugs me. How come I can go and see lots of people and complain of pain? For the first 3 surgeries, those complaints were perfectly legitimate enough to justify an operation. And when I still say, you know, you haven't solved the problem, I still got this pain, all of a sudden it's my fault, or it's illegitimate. Why is that? Why is the same pain that justified 3 surgeries not justify chronic pain management? You answer that one for me. I don't know. Maybe it's our fault. Here's the final one, and this I think I do have an answer for, and I think I want to leave you with that. I think the problem is that the dogmatic way of looking at pain, chronic pain, anything that you know is not something that gets better in a reasonable period of time. I think chronic pain is a disease. I don't think that it's a symptom. And I think the dogmatic way of looking at pain in the medical profession has always been that pain, no matter what kind of pain it is a symptom of another disease state. And I think we're changing that whole idea of how to look at pain. Because pain, when it becomes chronic pain, is a disease in and of itself. And it has its own set of symptoms, and it has its own set of morbidities, and it has its own set of problems with treatment. But if you continue to look at pain as a symptom of something else, then you fail to get the big picture. You fail to address the pain as an important disease in itself, and you're constantly looking for the wrong thing. And we stress this with our patients that come in through the chronic pain program. And I want them to understand that this is not necessarily a symptom of something else. And I think that if you just ask yourself some of these questions and come up with your own, and look at your own sort of reaction to not only pain, reporting of pain in others, how you deal with pain, how you perceive pain, how you plan on treating pain, you'll probably come up with more questions than answers, but I think that you'll get a lot out of the next couple of days. So I think that's all I have. Feel free to visit our website if you want more information or anything about sort of our approach and that sort of stuff. And please enjoy the next couple of days. Please participate, and thanks for coming.
Great.
Okay, we're going to get started now. Last summer, I had the opportunity to meet our next speaker at a training that the Alliance for State Pain Initiatives put on, teaching folks like myself on how to advocate for pain policy. Is my mic a little too loud? Is that? Okay, great. Dr. Robert Twillman is the Pain Management Program Director at the University of Kansas Hospital and Clinical Associate Professor of Psychiatry and Behavioral Science at the University of Kansas School of Medicine. A clinical psychologist, Dr. Twillman is the past chair of the Advisory Council of the Alliance of State Pain Initiatives and maintains an active interest in the impact of public policy on pain management. Please join me in welcoming Dr. Twillman. Yes, I should.
Great. Well, thank you. It's a real pleasure to be here. It's my first visit to Montana, and I think I'm definitely going to have to come back and spend some time because it's beautiful here. I envy you folks. What I'm going to do is to talk a little bit about common state pain policies. This is sort of pain policy 101 in a sense. What I'm going to do is take you through some of the common pieces of public policy that we see in relationship to pain management and talk about some of the advantages and disadvantages of each of them, some of the things to sort of watch out for as you kind of go forward in establishing new pain policies. Start off, and this has already actually been mentioned, that pain is a major public health issue for us, and certainly some of these numbers would support that. Chronic pain affecting 35 to 50% of adult Americans, which is an awful lot of folks having some kind of chronic pain problem. When people come in for health care, 80% of the time they're coming because they have pain. There is nothing else that's more common that drives people to come to see the doctor. 40% of acute care patients tell us they have poor pain control. And the striking thing for me about that number has always been that we know that when patients are in the hospital and we ask them, how satisfied are you with your pain management? They start to say they're very satisfied when their pain level gets down to about 7 out of 10. It really doesn't take much for them to say they're satisfied. But 40% of them are telling us they're not satisfied. So what does that suggest about where their pain levels fall? The support study that came out a number of years ago now, 50% of dying patients were reported to have moderate to severe pain during the last few months of life. Totally unnecessary. We can do a much better job than that. The National Institutes of Health tells us that unrelieved pain costs our economy over $100 billion every year. And I don't know about you, but I can think of a lot better ways to spend $100 billion. And I'm sure a lot of politicians could think of other ways to spend it too. But pain is not our only major public health issue that we have to grapple with. Unfortunately, drug addiction is also a major public health issue, and the numbers I'm about to show you actually all refer to only drug addiction with respect to prescription opioids, prescription painkillers. The 2004 National Household Survey on Drug Use and Health. Most of the time when you hear statistics quoted in the media, it comes from this survey. So this is one that's out there a lot. 2004, 31.8 million Americans saying they'd used a pain reliever non-medically at least once in their lifetimes. Now, non-medical use of a pain reliever gives you kind of a wide area in which to fall. That can range all the way from you go out and decide to play softball and you sprain your ankle, and so what you do is you go home and take some of the Vicodin that somebody else had left over from having their wisdom teeth pulled. That qualifies under the definition of non-medical use. So does crushing your OxyContin and snorting it up your nose. You know, they're kind of different things, but it's a wide definition. But even with that definition, there's a 7% increase over the 2 years from 2002 to 2004. Dawn data coming from emergency rooms in about 24 large cities across the country. 2002, 119,000 emergency room visits for narcotic analgesic abuse, which was a 73% increase from 3 years before that. Treatment episode data set. With this data set, what they do is when people enter substance abuse treatment, they ask them a number of questions, one of which is, what is your primary substance of abuse? Non-heroin opioids, which pretty much gives you prescription opioids, were the primary drug of abuse for 9,000 patients in 2003, and that was a 534% increase from 4 years before that. So there's no doubt that we have a problem with the abuse of our prescription pain medications. And so the question is, how do we properly balance these two things, these two public health problems? Because if we go overboard in trying to attack one of them, we may exacerbate the other. And so what we have to do is be mindful of this principle of balance. Opioid analgesics need to be available for those who need them to treat their pain. And we need to try to make them as unavailable as possible for those who have substance abuse problems who want to abuse those drugs or divert those drugs. And again, it's called balance because it is a difficult act. It's like walking a tightrope, trying to figure out, if you go too far to one side, you're going to fall off. If you go too far to the other side, you also fall off. You have to find sort of that narrow middle line here. So with that as kind of a brief introduction, let's talk a little bit about what makes a policy good or what makes a policy bad, or what are some of the good and bad features that we find in policies. Just to kind of brush you up on this or kind of refresh your memory, there are really three types of pain management policies that we see. There are statutes, laws passed by federal and state legislatures, pretty self-explanatory. We have regulations, which are basically instruments that have the force of law that are drafted by generally executive branch agencies as a means of enacting the law. So the law may say you have to have a certain policy. And so then the executive branch agency, the Department of Health or whatever, will take that and put that into specific terms, saying these are the things you specifically have to do to meet that requirement of the law. And the third type of public policy we have is really a guideline, which are typically used by licensing boards in pain management. They're basically rules of thumb or rules of procedure for how they're going to approach an investigation. If someone files a complaint against a physician or a nurse or a physician assistant, how is the board that regulates them going to approach that? What do they see as the key factors that someone has to meet in order to be practicing appropriately? David Jorgensen and his staff at the Pain and Policy Studies Group at the University of Wisconsin have been looking at these issues for a number of years. And they're actually the people, I believe, who first promulgated the principle of balance and put that out as something that was very well defined. What they've done is a number of times now they've surveyed all of the state statutes, regulations, and guidelines related to pain. And they're now into a place where fortunately they're able to give us annual updates on that. And are expecting, I guess, another one probably in September. It seems to be in the fall of the year when these come out. They've identified 8 sort of positive criteria to look for in pain policies and 8 negative criteria. And I just want to briefly walk you through those so you can get an example of what these folks think are sort of the key things that need to be in policies and key things to avoid having in policies. Some of the positive criteria, when you see these things in your state's laws and regulations and guidelines, this is a good thing. First of all, that controlled substances are recognized as being necessary for public health. They're recognized as the law or the regulation or whatever says, you know, we really need these in order to manage pain appropriately and to better the public health. Pain management is recognized as a part of general medical practice. It's something that every physician should do with every patient they see who has pain. It's not a specialty. It's general medical practice. The medical use of opioids is recognized as a legitimate professional practice. Pain management is encouraged by these regulations or guidelines. Some mention is made, some attempt is made to address practitioners' concerns about regulatory scrutiny. We know that one of the major barriers for practitioners in prescribing is the fear that someone like the DEA or the medical board is going to come knocking on the door and say, what are you doing? And take away your license and basically put you out of business. So there needs to be some acknowledgement that that's a frequent concern. The unfortunate thing is that a lot of times the perception of that concern or the perception of that problem is much greater than the reality of it. And unfortunately, changing perception is a lot more difficult than changing reality. Prescription amount alone is not sufficient to determine the legitimacy of prescribing. You know, there actually have been physicians in this country who have had their licenses taken away solely on the basis of printouts from pharmacies, showing that this patient got X number of pills over a certain period of time. And that's just horrendously inappropriate. Because we all know that, particularly chronic pain patients, you have to titrate the dose to each patient to find what's appropriate. And what may look like an awful lot of medication for one patient may turn out, in fact, to be just exactly what they need to keep their pain under control. So to look at just the numbers and make that decision is grossly inappropriate. Dependence and tolerance are confused with addiction. Many state pain policies are a bit dated, and they don't have accurate definitions for these terms. And then finally, just about anything else that might enhance pain management, any other kind of category or statement that shows up that can enhance pain management. The negative criteria are in many ways sort of the flip side of the positive. First of all, opioids are implied to be a last resort. The implication is that you have to try every other possible treatment before you can try an opioid. The medical use of opioids is implied to be outside of legitimate medical practice. Dependence and tolerance are confused with addiction. Medical decisions are restricted. Examples, for instance, some state pain policies, particularly intractable pain treatment acts, which we'll talk about in a little bit, say that the only time that comes into play is once the patient has been examined by 2 different specialists in the particular underlying disease that may be causing the patient's pain. So it restricts the practitioner from doing what needs to be done to treat this patient's pain until after the patient's been off to see 2 different specialists. And oh, by the way, will your insurance pay for that? Sometimes, sometimes not. Length of prescription validity is unduly restricted. Some states have actually had prescription validity lengths as short as 3 days. Once that prescription is more than 3 days old, it can't be filled. That makes life very difficult for patients. Practitioners are subject to other undue prescription requirements, such as requirements that they purchase specific kinds of prescription blanks from the state that have serialized numbers on them, have triplicate forms, and so forth. Anything else that can impede pain management, and ambiguous provisions, because ambiguity is always something that makes people anxious, and rightly so. If it's not clear as to what it really means or what your responsibility is, it's right to be anxious about that. So by looking at all the state pain policies and sort of making a grid of all these positives and negatives, it's possible to come up with, in essence, a letter grade for each state's pain policies to indicate overall how's the state doing. And this is the most recent map of that. Colors are a little difficult to see. I apologize for that, but that's kind of the way it came to us. And I can't personally tell whether Montana is a C plus or a C, but I'm sure you know. C plus. Okay, fabulous. And this is actually kind of exciting. 2006 is the first time in this review that anybody's gotten an A. And you can see Michigan and Virginia got A's. I'm proud to say that Kansas is going to get an A next time. It actually was mentioned in the text that if we had one provision that we got out of our policies, that we would be in good shape. And unfortunately, we missed the deadline for this evaluation by about 3 days. So I know that's going to happen next year. And I'm sure there are other states, too, that will make some progress with this. And if you track this over time, and I think some of those data are actually available in your binders, you can see that there has been a gradual improvement in states over time in improving pain policies. Now, the question, though, is if your state has a good pain policy, is it going to have good practice with respect to pain management? And unfortunately, the answer is not necessarily. Policy is permissive, it's not prescriptive. It allows you to do the right thing. It doesn't make you do the right thing. It's necessary, but it's not sufficient. Once the policy change takes place, then you have to go the next step, and you have to teach people the things that they need to know in order to make good use of that policy. So, as I said, it's a necessary first step, and for that reason, we need to make sure that that's all in line as we continue with our educational efforts and so forth. So let me run you through some of the examples, and these are kind of loosely clumped into legislative examples that require the passage of law, and non-legislative examples that can be accomplished by working with regulatory agencies within the state. These are some of the examples of legislative pain policies that are found around the country. I'm just going to walk you through each of these in turn, starting with prescription monitoring programs. And in talking about prescription monitoring programs, I have to admit to you, I'm somewhat ambivalent about these programs. The clinician in me says, gosh, wouldn't it be nice for me to be able to contact some state agency, and I'm seeing this new patient, I have no idea what's happened in their past, and I can contact this agency and find out what prescriptions they've gotten to see if they've been double dipping, if they've been doctor shopping. On the other hand, I think there's real potential for this to cause problems with the other half of that sort of principle of balance, with impairing pain management for patients. These programs are designed to track prescriptions for controlled substances as a means of identifying patterns that are indicative of abuse and diversion. The first of these was established in California in 1939, so they've been around in one form or another for quite some time now. Until recently, a lot of states required the use of special prescription forms. For instance, in California, there was a triplicate form. One copy went with the patient to the pharmacy, a second copy stayed with the physician, and a third copy also went to the pharmacy but then was sent on to a state agency that apparently put them in a box in a warehouse someplace and never bothered to review the data. There's now only one state that requires special forms. And now what's happening instead is that most of these data are being transmitted electronically, which is of course much more efficient and much more likely that these data are actually going to be usable. The Alliance what was then the American Alliance of Cancer Pain Initiatives, now the Alliance of State Pain Initiatives, put out a position statement a few years ago listing some of the desirable characteristics of these programs, or at least what we believe to be desirable characteristics of these programs. That statement is in the back of your binder for future reference. Congress has gotten involved in this. They passed a bill a couple of years ago called NASPR, which authorized grants of up to $60 million to states to establish these programs. Congress evidently was convinced that these are very effective programs, that they do a good job of controlling drug diversion and drug abuse. They were told that by the DEA and by the Department of Justice. But if you look at the data that support that, it's not at all clear that that's true. The primary data that was cited comes from a report from the Government Accountability Office. And what that GAO report says is that we know these programs are very effective, and there are three sources of evidence that tell us that. First of all, when we talk to law enforcement officials in states that have these programs, they tell us that it speeds their investigations by as much as 75%. Okay. Secondly, we see that states that have these programs, compared to states that don't have these programs, have a major reduction in the prescribing of oxycodone. And third, when we talk to law enforcement officials in states that have these programs, they tell us that law enforcement officials in neighboring states tell us that when a state establishes a program, there's an increase in diversion activity in adjoining states. Okay? Now, you know, regardless of what you think of law enforcement officials, they may not be unbiased observers in all of this. And the statistics that they cite to support the reduction in prescribing of oxycodone, first of all, not really even a statistic the way they cited it. And secondly, doesn't say a word about how much of that reduction in prescribing was prescribing to legitimate patients who actually needed it, but the doctors got so scared that they stopped giving it to them. So that's really not too helpful. As part of this legislation, Department of Health and Human Services was directed to do an evaluation of these programs, and I believe there's a draft report of that that's in process, so hopefully will be out not too long from now. I guess it remains to be seen what the quality of the data supporting that report will be. This is the status of state prescription monitoring programs in 2003. The red states are states that monitored only prescriptions for Schedule II controlled substances. The blue states monitored both Schedule II and Schedule III, and in most cases Schedule IV and occasionally Schedule V. But Schedule II and Schedule III are really where most of our pain medications lie, so that's why I've used that terminology. So that's 2003, and this is 2006. You can see they're sort of spreading like wildfire in a sense. And the reason that Iowa's got that kind of crazy crosshatch pattern is the way it was originally set up. It's set up to monitor Schedule IIs only, but they have the option to include Schedule IIIs at some point. So this is what's happened over the course of 3 years, and largely as a result of the NASPR legislation, but as a result of a number of other things too. And I'm somewhat chagrined, but on the other hand, not sure what to say about it, to report that our Kansas legislature has just passed a bill to establish a task force to evaluate the establishment of one of these programs. So, my ambivalence is going to be something that's probably going to come into play here in the next few months. Well, we do have a little bit of research about this. This is some research that I presented last year at the American Pain Society meeting, looking at data on the retail distribution of opioids. That's available actually on the website of the DEA on a report called ARCOS. And what I looked at were data from 2003. And I used that lineup of 2003 states to make this evaluation. And what you can see here is if you compare states that have a prescription monitoring program to those that do not have a prescription monitoring program, what you see is that for oxycodone, morphine, fentanyl, hydromorphone, and meperidine, all of those states where there was a prescription monitoring program, there was less prescribing of those medications compared to states that didn't have a program. Now, none of those is statistically significant, but I would put it to you that a 15.5% decrease in oxycodone prescribing may be clinically significant. And interestingly, the two that were statistically significant were increases in the prescribing of codeine and hydrocodone, which is a pattern that we call downscheduling, where patients who are on Schedule II medications are shifted to less effective, shorter acting Schedule III medications, largely because of the fear of monitoring of Schedule II prescriptions. So that's what we think is going on with that. And it's kind of surprising to me to see a 45% increase in hydrocodone in states that have these monitoring programs. Hydrocodone is and always has been the most commonly abused prescription pain medication. So in a sense, what these programs are doing is driving people to medications that are more commonly abused, or at least that's what it appears. Looking at measures of drug abuse, I already mentioned the TEDS and the what's now called the National Survey on Drug Use and Health. Again, comparing states that have prescription monitoring programs and states that don't, there's no difference in the TEDS data, but in the National Household or the National Survey, we do in fact find that there's a higher rate of drug abuse in states with prescription monitoring programs compared to those without programs. Now, as of 2003, all of these programs had already existed for at least 5 years. So it's not the case that these were new programs that were instituted because the states had a problem. These programs had been in existence in some cases for the better part of 60 years. But in all cases, for at least 5 years. So based on these data, it looks like it's a little hard to claim that these programs are actually reducing drug abuse. And it's suspicious that they may in fact be reducing adequate pain management. If you look at the nature of the programs and which schedules they monitor, you also see some interesting patterns. Two of these are statistically significant. The first one is oxycodone. Interestingly, states with no programs and states that monitor both C2s and C3s are no different from each other. But states that monitor only the Schedule IIs have a major decrease in prescribing of oxycodone. You see a similar pattern with morphine. And what you also see is that the more restrictive this program or the more comprehensive these programs are, the more codeine and the more hydrocodone are prescribed. I don't understand that personally. I don't understand why a program that monitors the Schedule III would be likely to cause people to prescribe more hydrocodone. That doesn't make a lot of sense to me, but that's what the data suggests, at least for the year 2003. Looking at the same data with respect to our measures of drug abuse, no difference in the TEDS data, but we see a similar pattern with the National Survey data. Again, the states with the more comprehensive monitoring programs have higher rates of drug abuse. So the bottom line is, these programs as a clinician are things that I would like to see, but based on these data, I have to wonder if A, they're really all they're cracked up to be, if they're really doing the job, and B, if they're not perhaps in fact causing more harm. And to some extent, I get the picture of this as being sort of like killing a housefly with a hand grenade. It's effective, but it also causes some collateral damage. And that's what concerns me about these programs. They may or may not pick up people who are diverting the drugs. And the thing about it is that all of these are really monitoring as prescriptions. And we know there's a tremendous amount of drug that's acquired from other sources, particularly from thefts from the distribution pipeline. So I'm not sure these programs are all they're cracked up to be, and I think we have to be very careful in establishing them. Look at the policy statement from the Alliance of State Pain Initiatives and think about the characteristics that we're suggesting there. But I think the other thing we have to do, and this is one of the characteristics that's listed, is to say there must be an evaluation of this program somewhere down the line to look to see if it's really doing what we think it needs to do and not causing more harm to patients. And if it in fact doesn't accomplish what it's after and it causes harm to patients, then maybe they should go away. Maybe that should be written into the law. Maybe it should be a sunset clause in there that they can't continue unless they demonstrate their effectiveness. Just some thoughts about that. Now, a second type of legislation is the Intractable Pain Treatment Act. And typically what these are intended to do is to let clinicians know that if you have a patient who has intractable pain, it's okay to treat that pain with whatever means are necessary. That's the intent of these. But the problem is that oftentimes they contain some provisions that limit practitioners' actions, such as I mentioned before, requiring consultation before this really kicks in. They often also contain some confusing language. These are some of the problematic features we see in intractable pain treatment acts. First of all, an unclear definition of intractable pain. The definition that's most commonly cited is pain for which the cause cannot be discovered or removed. So in order to qualify for a diagnosis of intractable pain, you have to do what's not possible, and that's prove the negative. You have to prove that you can't find the cause or can't get rid of it. And you can never prove the negative. So in one sense, these laws should never actually go into effect. There's a requirement in some that all other treatments be tried before opioids. Requirements for expert consultation we've mentioned. Some have prohibitions against giving controlled substances to people who are known or should be known to be abusing drugs. I'm thinking about a contract with the psychic hotline to find out which of my patients I should know are abusing drugs. In fact, in some states, these laws specifically say if the patient has a substance abuse diagnosis, you may not give them a controlled substance. Okay? Which leaves you wondering what happens if somebody goes out and gets liquored up some night and has a car wreck and comes in with a bone sticking out of their leg. What are you supposed to do with that? If the law says you can't give them an opioid, here's some Tylenol. That's not the intent of that law, but that's what it says. Now, what we know about these is that where there has been an apparent impact, it's generally been a positive impact. And Ann may be able to speak to this from Missouri. We saw that when they passed this law, there were a lot of changes in the way in which the Bureau of Narcotics and Dangerous Drugs approached physicians. And it appeared to cause some positive change. But it's not been evaluated systematically. And we don't have really good criteria to tell you based on research what needs to be there and not be there. The Alliance of Cancer Pain Initiatives, the Alliance of State Pain Initiatives, does have this position statement. This is the link for the website. It's also included in the back of your binder if you want to look at this. And these are states that have intractable pain treatment acts. So you can see there's sort of a scattering of these. We haven't really seen a lot of new ones recently. And it's not something we're particularly encouraging states to pass, just because of all the complications that are involved with these. State pain commissions or task forces. I really don't have to talk to you folks about this because you're obviously one of the states that's done this. Typically, of course, these are established by the legislature, appointed by the governor. Then the charge is to evaluate the scope and nature of the problem and make recommendations for what to do, which is exactly what you've done. Many of these are temporary. As far as I know, Oregon's is the only one that's permanent. This is actually, I think, a very constructive way of approaching the problem. To have an organization like this that has a mandate from the legislature and from the governor to come back with some recommendations about what to do. So these are states that we know of had state commissions or state task forces. Healthcare facility pain standards. These are also known as sort of pain as the fifth vital sign legislation. And this has happened, I believe, in one state, or perhaps two states now that have passed these laws, saying basically that healthcare institutions have to treat pain as the fifth vital sign. They have to assess it on a regular basis, reassess, and so forth. Some states have implemented these kinds of policies through non-legislative approaches, through a regulatory approach instead. What they do is, as I said, require certain standards with respect to assessment and management of pain in licensed healthcare facilities. Now, the pro of that is that while the Joint Commission has similar standards, not all healthcare facilities are JCAHO accredited. I don't know what the case is in Montana, but I know that in Kansas, about 50% of all hospitals are not Joint Commission accredited. Those in the rural areas don't tend to have the money it takes to put everything in place that the Joint Commission likes to see. So having a law like this or a regulation would cover all of those that are not Joint Commission accredited. The con, of course, is that this is very difficult to enforce, and we have no evidence that it's helpful. That's not saying it's unhelpful, it's just we don't have evidence to support the effectiveness of this. So the jury's still out with respect to these kinds of laws. Palliative care and advanced directive laws. A lot of these contain some references to pain management practices. And for the first time, the 2006 Pain and Policy Studies Group evaluation included these laws. Some states, again, have addressed these issues through regulation as opposed to the statutory route. What these laws need to say, if they're going to be laws, is that there have to be references to pain management. that are such that they don't interfere with the patient's ability to receive whatever type of pain management is necessary, including what's commonly termed as being terminal sedation. These laws, along with laws about assisted suicide, is where we most typically see language about the principle of double effect. Those of you who are familiar with the principle of double effect, it basically says you're okay to treat pain as long as you're intending to really treat pain and not intending to euthanize the patient. Okay, moving on. Mandated continuing medical education for pain management and palliative care. And for that matter, mandated education for nurses, for psychologists, physical therapists, other groups as well. These mandates can either be legislative or non-legislative. Some states, doing this requires that a law be passed. In other states, the licensing board is free to set these criteria, these requirements for continuing education, but you might have to pass a law in order to actually get them to do it. Some states have chosen to put out language encouraging continuing education rather than mandating it, which tends to be a little bit better received by the medical community, by the way. The problem is that education alone is not sufficient to change practice. It's another one of those things that is necessary but not sufficient, just like good policy is necessary but not sufficient. It is necessary because you can't do what you don't know. And if you don't know how to manage pain, you're not going to be able to do it appropriately. So, in one sense, this may be something that's helpful, but it's not the only thing that's going to be necessary. The problem is that what you have to change here is not only knowledge, but attitudes. And as we all know, changing attitudes is a lot more of a challenge than changing knowledge is. Some states have chosen to establish this as a one-time requirement. Others have made this a requirement for each license renewal period, so that each time the license is renewed, you have to demonstrate a certain number of hours of continuing education. The jury's still out with respect to the effectiveness of this approach. It's too new to really evaluate. It's only been in place in a couple of states for just a few years. If you're going to attempt something like this, it's very important to work with the practitioner groups, because they're likely to oppose it if they're not part of the process. I floated this idea in Kansas a couple of years ago, and one of our greatest supporters is the executive director of the Osteopathic Association in the state. And I said to him, what do you think about this idea? He said, well, to tell you the truth, if it came from someone else and was part of legislation, we'd probably oppose it. But if we were part of proposing it and it came from the medical board, we'd probably support it. Okay, so it's really important to involve these stakeholders up front when you go to make this kind of a decision. And what you may choose to do is more of a stepwise approach. Start with asking the medical board to require that when people send in their license renewal, they indicate how many of their hours of continuing education were in areas of pain management and palliative care, just to get a baseline. And maybe having that baseline showing that it's, 5%, may in fact be enough to spur some requirements. So that may be a way to approach that. The red states here are states that encourage continuing education. The blue states require it. Okay, moving on to non-legislative pain policies. The most common of these have to do with professional board licensing, or professional licensing board guidelines. I'm going to spend a little time talking about Medicaid and its formularies and its preferred drug list process, and then just touch briefly on workers' comp and insurance regulations. Licensing board guidelines, as I said, are sort of the rules that lay out how a licensing board is going to proceed in the event of a complaint against a practitioner. What they do is give practitioners a standard of care that's a lot more objective. It says to them, this very clearly, on paper, is what we're going to expect from you. It also reassures practitioners because now they have a clear idea about what's going to be required. Previously, when there's no statement on paper, it's sort of like, I don't know what they're going to do if someone files a complaint against me. Now they've got it in writing. They're told by the board, this is what we expect to see. So they have some pretty clear guidelines. That should relieve anxiety. The Federation of State Medical Boards first passed a model guideline in 1998, and then in 2003 revised that, called it a model policy. I'm always proud to say that the 1998 model guideline was first adopted by the Kansas Board of Healing Arts. It's one of those times when I can brag about us being ahead of the curve instead of having to talk about things like evolution and that type of thing. Many states have used all or parts of these model statements in their guidelines. And again, these are more likely to be effective if they're adequately publicized. It's really important that once this is adopted by the medical board, that copies of it get distributed widely and that they get referred to these on a regular basis so that they remember that they're there. These model policies, unfortunately, tend to refer only to physicians. They don't take into account other prescribers like nurse practitioners and physician assistants, although the principles are the same. So we have a need to address other populations of prescribers. Dentists occasionally get involved in this too, because they do manage pain. They do prescribe pain medications and so forth. Podiatrists occasionally get involved with these policies. Some state nursing boards and pharmacy boards have also issued guidelines, and some states, like I know you have here in Montana and like we have in Kansas, have also issued joint guidelines from the licensing boards coming together. These are states that have adopted the model guidelines or the model policy in whole or in part. And you can see it's an awful lot. And I know your medical board has actually adopted 2 statements, one on their own and one as part of a joint statement. It's not based on the model guidelines, so that's the only reason it's not in blue. It's not absolutely necessary to use those model guidelines. It's just as long as what's in there meets the criteria that we set forth in the beginning. But you can see these actually have been pretty popular. And a lot of medical boards have thought this is a good idea. These are states that we know have positive nursing policies. And these are states that we know have positive pharmacy policies. Okay, so as you can see, this is sort of something that's sort of spreading. Again, in some cases, the reason that nursing and pharmacy get included here is because they're part of a joint statement. In other states, they've actually issued their own unique statements. I think the more statements that get issued, as long as they're consistent with each other, the better off you are. Because these really tell the practitioners regulated by each board what they're expected to do. Okay, Medicaid programs. You know, Medicaid programs, of course, are partially funded by the federal government and partially by the state governments, but they typically represent the largest single area of expenditure for states in their state budgets. And so, of course, anytime there's a state budget crunch, where do they want to start cutting? Well, they want to start cutting with whatever's the biggest in the budget. And so Medicaid is under constant pressure to reduce its budget. One way they can do that is by controlling which medications are on their formulary, which medications they're going to pay for if they're prescribed to their patients. So they can have some control over which medications they'll pay for at all. And then once they've established that, they can go through the second process to establish what are called preferred drug lists, or PDLs, which say that within the class of, let's say, opioid analgesics, our preferred drugs are morphine and methadone, which are probably the two most common. And only after a patient tries those two and doesn't achieve good pain management can you move on to something else that is, oh, by the way, more expensive. So that's the way these programs are typically set up. You have to have prior authorization to use something that's not part of the preferred drug list. The other thing Medicaid programs can do is require drug companies to provide something called a supplemental rebate to have the drugs included in their formulary. Supplemental rebate is a euphemism. What it really means is a kickback. Okay, they require basically that the drug companies come in and say, okay, for your program, we're going to sell this drug to you at a much, much lower cost. Okay, it's in a sense the Medicaid authorities strong-arming drug companies into doing that by saying, if you don't, we're not going to include it at all. We're not going to allow our patients to use it at all. A PDL committee, and most states have these committees that meet on an annual basis to review the preferred drug list. These committees are charged with reviewing the drug classes to recommend preferred agents within each class based on 3 criteria. First, efficacy. Do they do what they're supposed to do? Second, safety. Do they do it in a manner that's safe without any untoward side effects? And third, cost. And it's supposed to be in that order. I'm not sure it's always in that order, but that's the way it's supposed to be. Typically what they do is they hire consultants to come in and give them recommendations. The members of these committees may be members of the state Medicaid DUR board, the Drug Utilization Review Board. They may be people who are not part of that process who've been brought in too. But basically what you've got is a bunch of practitioners, some of whom are specialists, some of whom are general practitioners, and they're charged with reviewing every drug in the pharmacopoeia. Okay, so for a pain management specialist to be on one of these committees may be a nice thing when it gets to evaluating nonsteroidals, COX-2 inhibitors, opioid analgesics, but that person's also going to have to evaluate antihypertensives, antihistamines, you name it, everything. And I'm sorry, nobody has either that much time or that much knowledge. And so that's why they hire consultants to come in and make recommendations. The committees typically hold public hearings at which members of the public may testify. And it's striking, I've been to a number of these meetings to testify actually, and as it turns out, apparently about 95% of members of the general public work for drug companies, because that's who testifies. You know, and what happens is representative from drug company A gets up there and starts spouting statistics from studies about his particular drug, and his time's up, and representative from drug company B gets up there and starts spouting contradictory statistics, and after about 2 minutes, everybody in the committee's got this glazed look on their eyes. They don't have a clue what's being said anymore. But I'll tell you what's really effective is when someone gets up there who's not attached to a drug company and says, I want to talk to you about this because I'm concerned about what's going to happen to patients. And this is a really important issue, and you need to think about this. That grabs their attention. These folks are almost all clinicians, actively practicing clinicians. And so don't underestimate the power you have to go in there as someone who's not related, not pitching a particular drug, but instead saying something along the lines of, what we need to have is all long-acting opioids as part of the preferred drug list. Because individual responses are so varied, we have to have ready access to all of these to manage our patients' pain adequately. This is the way the process works sort of graphically. The consultants make recommendations to the PDL committee, which makes recommendations to the DUR board, which makes recommendations to the agency that administers the Medicaid program, which establishes the PDL. And none of those recommendations is binding. They can change at every step along the way. So if you're going to get involved in monitoring this, you kind of have to go to all the meetings and hear what's being said in order to make sure things don't get switched on you along the way. Once a drug is kept off the PDL, you have to have prior authorization in order to prescribe it and dispense it. And the other thing that comes into play here is that states have a great deal of variability in the percentage of prior authorization requests that are granted. In some states, it's practically a rubber stamp. You send in the paper, they rubber stamp it, the patient gets what they want. In other states, it takes an act of Congress to get one of these approved. So you also have to know not only what's on the PDL, but the agency that administers that and how they approach that. You have to know what their likelihood is of approving these things. Okay, workers' compensation, also a very expensive area of government health care funding. It's one that we've just started to really kind of become aware of with respect to the regulatory environment. Lots of states have tried to control expenses in this area by doing a lot of the same things that Medicaid have done, by restricting the scope of services available to patients, restricting access to particular medications. There seems to be a large concern within this population about substance abuse, and that leads them to restrict access to opioids. States, as I said, have sought to establish processes much like the PDL, the prior authorization program. Some of those processes impose some very, very arbitrary restrictions. I know the state of Washington, they're having a big struggle right now because apparently their workers' comp folks have decided that any dose of an opioid that's higher than the equivalent of 90 milligrams of morphine per day is just not appropriate. And so that not only is that just flat out wrong, but the issue is that has potential to spread to other areas of government too. And so we really have to work hard to try to watch these things and make sure they don't cause problems for us. Now, with respect to state insurance regulations, some aspects of insurance coverage are controlled by federal legislation. Others can be subject to state regulation. What some states have done is established regulations, and others have used laws to do this, mandating certain coverages for pain management and for palliative care, requiring, for instance, that all insurance policies sold in the state have a hospice benefit attached to them. Those kinds of requirements have been put in place in some states. You really have to watch out to make sure that patients have adequate access to appropriate range of pain management interventions, because what tends to happen is those that are non-pharmacologic and non-interventional, groups like physical therapy, occupational therapy, psychology, and so forth, tend to get the short end of the stick here. The coverage for those tends to be very limited, and unfortunately those have great potential to benefit patients, especially those with chronic pain, who represent a large part of the outlay of these insurance programs to begin with. So that's the areas in particular that have to be considered, and you sort of have to be vigilant to watch out for if you're going to get involved in this arena. And I think that's the end of the course. So questions, comments? Yes?
Have you had any experience, or is anybody looking at Medicare Part D programs? Because I've had an experience with one particular Medicare Part D company, insurance company that deals in nursing homes, and they basically don't give you morphine elixir on their formulary.
Nice.
Yeah, it's great.
Yeah. Well, you know, that the whole Medicare D thing is something that's kind of new, and I don't think we've really looked very closely at it yet, but you would expect a lot of the same things that you see with Medicaid and with the insurance companies to carry over into that, especially since it's really administered by these private insurers. So I think you're going to expect to see a lot of those are going to have some of the same limitations you see with the private insurance companies, and it is something that you have to be vigilant about and try to advocate for your patients. Becky?
I'm kind of struggling. I need you to tell me where to find more information about the double effect language. As a critical care nurse, I've been, we give 10 milligrams of morphine to an obtunded person and extubate them.
Yeah.
I mean, I finished my sentence. I need to find out more about what that is, because it happens a lot.
Okay, I'm sure we can come up with a reference for you on that. And actually, there was also just a really interesting article published looking at patients in hospice, showing that in fact the data did not suggest that increasing doses in patients as they get close to death shortens their lifespan. In fact, there's maybe some evidence that suggests it actually prolongs life. So we'll get you some references about that. Now, the principle of double effect, just briefly, goes all the way back to Thomas Aquinas, and he was talking about the act of defending yourself against an attack and unintentionally killing someone in the course of defending yourself. In the context of pain management, what it really has to do with is you have to meet 4 criteria if you're managing pain. First of all, the act itself, the giving of the pain medication, has to be seen as morally good or at least indifferent, so not inherently morally wrong. Second, only the good effect must be intended. In this case, we're talking about the pain relief as opposed to the bad effect of the patient ceasing to breathe. Third, you cannot achieve the good effect by way of the bad effect. So it's not okay to kill your patient to relieve their pain. Okay, that's where Mr. Kevorkian gets himself in trouble, because nobody has shown that carbon monoxide relieves pain. And then finally, when you consider the likelihood and magnitude of the outcomes, the good has to outweigh the bad. And typically we don't have a problem with that when we're treating patients who have pain, because we're not intending to cause them to stop breathing. We're really intending to help relieve their pain. And the thing is that those of us who work with patients who have been on chronic opioid therapy know that the tolerance that they build to respiratory depression is very robust. You practically can't give people who are opioid tolerant enough opioid to make them stop breathing. And so I'm not sure in reality how much help that principle of double effect is. But it's language that gets inserted to reassure people.
A lot of times they're medicating the family because they're afraid that somebody's in pain. I mean, but it's all working at the same pace there. You're giving a med, you're an attended person, you're giving a big dose, and you're extubating. And usually within a short period of time, things are changing.
That's right.
But a lot of times it's a family relief thing.
Yeah, you're right.
Yeah, I need to learn more about that.
Okay, we'll get you some references. Yes?
I just wanted to mention I am on the Montana Medicaid Revitalization Board.
Great, thank you.
And she's on our task force.
Okay, fabulous. Okay, well, thank you very much for your attention.
While everybody's taking their seats, I just wanted to take this this opportunity to thank the Missoula Community Access Television station in the back for recording this event. They are going to be airing the event later on, and they'll let us know when that'll happen. So we'll send that out to you so you can let your network of friends that are and colleagues that are interested in pain management know about that. We'll also receive a copy of that recording, so if you ever want to, share that with a colleague, please let me know and we'll get that out to you as well. All right, looks like most of us are back in the room. So the next part of our evening is to really take a look at what we found here in Montana. The task force has, like I said, been working very tirelessly to try to put together all of our findings and make recommendations about what we can do strategically to work to improve pain management policies here in Montana and practices as well. And we had asked one of our task force members if they would be willing to write this paper for us, and Lindsay Unicello had graciously agreed to do that. So she's going to highlight our findings. The white paper is in the inside of your binder in the front panel. Now we'll have an opportunity after Lindsay visits this evening to have an open mic, so people please feel compelled to give us your feedback on the white paper, and then also in general what policy barriers you're experiencing. We'll have this white paper open for public comment for at least 30 days. So, if you don't have all of your ideas and thoughts about the white paper tonight, you will have an opportunity to provide us with more feedback and input. All right. Lindsay, you're on.
Okay. Well, it is an exciting night. Appreciate you all being here, and I just think this is really a celebration of a lot of work that has gone into rolling out this white paper and several years of task force work. It's been 2 years since the legislature met and gave us our mandate, and I think I met with Kristen back when I was working at Lifespan Institute several years ago, maybe 3 years ago, to say, hey, let's talk about getting a task force going here in Montana. And so it's great to see all that work culminating in our recommendations, which then begins a whole nother phase of work. But this is a good night for public health in Montana, and I think we should celebrate that. So also thank you for being here for this and being here on a Friday night. Let's see, the first thing is, as we have talked about, the Montana legislature in 2005. So part of the mandate that was given to the task force, indeed we are a body to gather information and then provide advice and recommendations. And so, the joint resolution said, in part, it is the intention of those who will participate on the task force to hold public hearings, to gather information from the public on issues pertaining to pain and symptom management, and then to provide advice and recommendations to appropriate public and private entities. So that is where we are at right now. Is the white paper is our report and our recommendations. Though the recommendations of this white paper are based upon public survey data, which we'll be talking about, literature review, and the diverse expertise of the task force members, working together to come up with recommendations that we could all agree on. Indeed, this, as you will see on the white paper, it says draft. As Kristen mentioned, it is open for public comment, so this is our second to final draft. We do want to hear back from you about what we are recommending here. And then just for the audience of the white paper, it is certainly to the Montana legislature to report on the mandate they gave us and what we've found and done. to the governor, to the director of the Department of Public Health and Human Services, and then to all those interested in pain management in Montana. So that's all you, and hopefully many more. So let's see. One of the first things, as we just saw in that mandate there from the joint resolution, was to talk about getting information from the public. And so one of the ways that the task force decided to do this was to host some public forums and to have a survey that we would be getting out there in the public. We were not able to do a full random sample mail out survey, and started with, we'll take this to these public forums, and as people show up, we'll hand out this survey and ask them to fill it out there on the spot. And there are 8 public forums around the state. They were not particularly well attended despite efforts to publicize. And so then the task force went on with other methods of getting that survey out there. And so some MSU College of Nursing students took these to flu clinics, to 2 different flu clinics, and then we worked with 2 chiropractic offices, 2 family practitioners, and 2 pain specialists to pass these out among their patients. And then also task force members were asked to circulate them in their, among people that they know and work with. So this is not a random sample. There are certainly some drawbacks to that, which is just in terms of generalizability. We can't say this is what Montanans think about pain, but the data still has a lots of important messages for us. So first, we're going to talk about some of the things that we found, and there's 3 sorts of findings that we're talking about. One is people's experience with pain, one is people's experience with pain management, and one is attitudes about pain and pain management that we were able to see through the survey. And there, in the back of the white paper, there is an annotated survey, which is the survey with the percentages then for each of the questions. And there's more data than I can talk about in just this time period, but please take a look at that, because it's really some great data in there that we can continually come back to, I think, as we move forward with some of these recommendations. So just in terms of experience with pain, 69.9% of the respondents report that they have a household member who has had chronic pain. And Dr. Twillman had put up a slide earlier that said in the general population, that's 35 to 50% is typical. So this is a little higher. And then again, 64.2% of respondents answered yes when asked if they have ever had chronic pain. And of those 64.2, 80.1% report moderate to severe pain, and 56.6% say they have experienced chronic pain for more than 3 years. So this is a pretty significant pain problem, and people living with it for multiple years. Again, these numbers are elevated than the general population, and that's probably due to the way that we distributed these surveys, using patients at chiropractor and flu clinics and pain specialist offices, and circulated through the task force. So while we it may seem like a more elevated pain experience than perhaps in the general population of Montana, we might expect these people to know more about pain management, and okay. So then this is talking about pain's impact. Folks who had said that indeed they had experienced pain, chronic pain, or that they had a household member who had experienced chronic pain were asked how that's affected their lives, and the 95.9% of those with the blue is the dark blue is the self. If you yourself have experienced chronic pain, the light blue is the household member. So high percentages here saying that it's limited their activities. incurring extra expenses for treatments or medicines, then that's again in the 60 percentile, so quite a number. And then also lost wages, we have over a quarter, well, almost a quarter for themselves and over a quarter for households saying that they have experienced lost wages due to pain, and that is, you know, a self-impact, household impact, and then also an impact for productivity and in the community at large. So let's see, next one. In terms of experience with pain management, these are some really interesting statistics. First, my doctor always believes me when I tell him or her that I have pain. You see that there's quite a lot of folks that indeed say that they believe that their doctor believes them. So almost 60% of respondents agreed or strongly agree that their doctor believes them when they report pain. Yet 38.9% of respondents opposed or strongly opposed the statement that when they have had pain, it has been well controlled. So I'm sorry, I didn't mention the scale. Our scale was 1, strongly support, and then down to 5, which is strongly opposed. So you could have obviously strongly support, neutral, oppose, or strongly opposed. So there's a disconnect here because we have people saying that their doctor, they can tell their doctor believes them or that they feel their doctor believes them, and yet the pain is not controlled. By over a third, almost 4 in 10 people are saying that it hasn't been well controlled. And yet they are indeed telling their healthcare provider about their pain. 87% who have had chronic pain report that they did tell their physician or their provider that they were having pain. And they did feel that they were treated with respect and dignity. That was a yes/no question. Do you feel like you were treated with respect and dignity when telling them about your pain? And so that's, great. 70% are saying yes, but then it drops again for were you listened to or taken seriously about your talking about your pain, and over a quarter are saying that they didn't feel that they were listened to or taken seriously about when they're reporting their pain. So now, we're having over a third are saying that their healthcare providers are not asking them good questions, and over 4 in 10 are saying that there's no regular monitoring, or is the physician regularly monitoring how their pain is impacting their daily life. And then over a third, or almost a third, are saying that their treatment is not adjusted if it is not, if their pain continues. So there's just some obvious issues that could be dealt with about how pain is being managed. And then also, the question is, have you been referred to any of the following if your pain continues? Physical therapist, pain specialist, naturopath, chiropractor, or no referral? And over a third said that they never received any referral. And then we see physical therapist at 45%, pain specialist at 17.3%, naturopath at 7.9%, and chiropractor at 20.9%. Okay, let's see. The next is attitudes about pain and pain management. In general, patients did not seem to say that talking about pain was taboo. 74.7% said that they disagreed with the statement. 74.7% disagreed with the statement that good patients avoid talking about pain. 57.6% strongly disagreeing with that statement. So that's good patient. A large majority of our patients are saying that they feel comfortable, or at least not saying that they wouldn't be a good patient if they talked about their pain. Also, They seem to be rather optimistic about whether pain can be relieved. 59.3 support or strongly support the statement that pain can be effectively relieved. Though almost a quarter were fence sitters on that. 23.7 saying that, registering neutrally that they did not know, I guess, whether pain could be effectively relieved. Also, 57.9% did not agree with the statement that pain medicine cannot really control pain. So almost 60% are saying that they believe pain medicine can control pain. And then there's some openness to non-pharmacological methods of treatment. 76.2% oppose or strongly oppose the statement that pain medicines, prescriptions, and over-the-counter drugs are the only effective way to relieve pain. So that's over 3/4 that are saying that there's other effective ways to relieve pain. Despite the general optimism regarding pain relief, some respondents also evidenced adherence to common myths about pain and pain management. Almost 3 in 10 respondents, that's 29.3% or 0.5%, believe that most people taking pain medicines will become addicted over time. So that's a pretty high percentage. And then 1/3 believe that people get addicted to pain medicine easily. And more than 1/4 of respondents, 27.4%, believe that pain medicine should only be taken when pain is severe. And 41.5% agree that it is important to take the lowest amount of medicine possible and save larger doses for later when the pain is worse. So there are some recommendations that after looking at this data and then also looking at the literature reviews and the expertise advice from task force members that the task force is putting forward 9 recommendations. And there's 4 different types of recommendations that we're making. Certainly pain is a very multi-dimensional issue, and so these are kind of broad categories, and to help us think about all the different ways that policy and practice and personal experience all come together to influence how pain is managed on a day-to-day level. So we have evaluative recommendations, organizational recommendations, policy recommendations, and educational recommendations. So to begin with the evaluative recommendations, the task force recommends that we integrate pain surveillance into existing statewide health monitoring systems in order to establish a high-definition picture of the incidence of pain in Montana and its impact on the health of Montanans. The task force is recommending that the Department of Public Health and Human Services look at different current measures of pain that are out there and include them in their administration of the Behavioral Risk Factor Surveillance System, which is a survey that is done by the Department of Health on a regular basis, and to include questions about pain and pain's impact in that survey, so that as Montanans we would have a great baseline of data about its incidence in Montana. And then that data would be able to be used to help us, inform our program planning, and also to help us know how to evaluate the methods that we have going forward. Next recommendation is to support initiatives that will conduct large-scale studies of patients, healthcare providers, and pain management systems in Montana. As we were talking earlier about the providers, the public survey, one of the things the task force had wanted to do is a survey of healthcare providers, and that was sort of outside of the resources of the task force. but we know that it's something that really needs to be done. And as Dr. Twillman was saying, that possibly one of the ways to look at encouraging CMEs for providers, to know what those CMEs should look like, we need to have a better baseline about what are some of the issues, the attitudes, the knowledge base for providers that are dealing with pain on a regular basis. And then certainly our insurance and health policies, that pain is not treated as a disease system, and so there's a limited scope of coverage for pain management. It's, they're typically very treatment driven, and not looking at comprehensive pain management. And so what would that look like under our insurance and health policies? And we weren't able to conduct a full survey of that. And so one of the recommendations of the task force is that does go forward, and that we support that happening. And the same with workers' compensation. One of the statistics I read was that 10% of the cases in workers' comp account for 90% of the costs, and often that is people with ongoing pain. And so looking at how pain claims are treated under workers' comp, and again, what comprehensive pain management look like, and then being able to make recommendations to the State Work Comp Act is one of the things that the task force is recommending. Then in terms of organizational recommendations, so to support efforts to create a robust Montana pain initiative. So the task force, as Kristen said, has completed its work of making recommendations, and the pain initiative is now going to be in the place of growing and carrying forward, and beginning to implement the things that are recommended here. And so that would be also being able to implement education outreach, but advocacy as well for better pain policy. And the next recommendation is to build institutional commitments to improving pain and symptom management. As Dr. Sechrist said at the very beginning, I don't think you can do this without an organization that believes in the vision and is committed. And so one of the things that the task force did early on was to create a standard of care that say, this is what we agree on, this is the standard of care that's in the white paper, and then to send it out and ask organizations to sign on in support of the standard of care. So we are kind of all on the same page of what is appropriate pain management, at least at a basic level. What are the basic standards? And so certainly working to have that standard be circulated even wider, and then actually working on implementing what sorts of things can be done to implement it. And there's, possible steps might include what are some of the partnerships. I know that Dr. Sechrist again was talking about how St. Pat's is moving in a direction of really having a lot of relationships with outlying areas and being a place of, sounding like some building relationships with people, with organizations and other facilities, and how to help them, people in outlying areas that maybe aren't able to be in Montana's more urban areas, still have effective pain management. And so what are some of those partnerships that could be created? What sorts of policies and procedures need to be created at institutional levels that affirm that pain management is an important part of the mission, and to put pain management into patient satisfaction surveys. I know that is in at St. Pat's, and just being able to have that feedback loop so that it's part of the continual quality improvement and the patient feedback. And then to create interdisciplinary pain teams. These are all just some ideas of how to build institutional commitment, and I'm sure there are many more out there that you guys all know. I'm not in a clinical setting, And that would be one great thing to get feedback for to include in the white paper. In terms of policy recommendations, what the recommendation the task force is making is to modify existing or adopt new policies that could enhance pain and symptom management in Montana. As Dr. Twillman said, the Pain and Policy Study Group gave Montana a C+ for our state pain policies. And these are the policies that are on our books that they reviewed. The Controlled Substances Act, the Medical Board Guideline, and the Joint Policy Board Statement that he discussed. These are ways that we could really improve our rating, and not just to improve the rating, obviously, but to have good pain policies out there. And the first would be for our Montana Board of Medical Examiners to consider adopting the model guidelines from the Federation of State Medical Boards that he already mentioned. Though we have, the guidelines, we do have some negative things in there. We received good points on what he was explaining was those positive affirmations and then the negative that retract from our grade. So the positive that we have is that in the Montana policies, there's the affirmation that opioids are part of professional practice. We do encourage pain management. We address the fear of regulatory scrutiny. We represent the idea that efforts to reduce misuse of controlled substances should not interfere with appropriate medical practice. That's that concept of balance he was talking about. And we recognize that treatment goals include quality of life and patient functioning, not just decreased pain. Those are all in the statements in some form, and we're given what we got our good marks for. But the things that detracted from our overall grade is that we suggest in our policies that prescriptions of opioids is a last resort, and we have some things that restrict medical decisions. So if we were to adopt the Federation of State Medical Boards guidelines, we would be able to get rid of those negative provisions. Also, we should amend the Montana Controlled Substances Act to affirm that controlled substances are necessary for public health. And then we also recommend that professional licensing boards consider guidelines for symptom management and communication between professional disciplines for optimal pain and symptom management. So saying that, we expect that there will be interdisciplinary collaboration on this issue for the licensing boards to say that sets a pretty high standard, I think. In terms of more policy recommendations, this was something that Dr. Twillman talked about as well, that require or encourage continuing education in pain and symptom management. 81% of the people surveyed by our public survey who said that they felt that there were barriers to pain management in Montana identified lack of health care provider training as one of the barriers. And as Dr. Twillman said already, said a lot of good things here, that knowledge is not alone going to change attitudes and change practice, but it's certainly a good step, and it also has the for us to encourage, require or encourage continuing education in pain management is to say that this is important. It's for our state to affirm that we think that this is an important part of and integral to medical practice. And so besides giving the some important information, it makes a very necessary affirmation. In terms of educational recommendations, one of the things that we say is encouraging licensing boards and professional associations to regularly inform licensees and members about pain management policies and guidelines. And I think he already said that again tonight, which is it's great to have these things, but get them out there to your members. Let your members know what the guidelines are. Recirculate them, and for one of the things the pain initiative, as it goes, could look at is how to work with our medical board and our professional associations about continually getting that information out there. And then encourage the development of public education regarding effective pain management. From the Healthcare Consumer Survey, there's definitely suggestion that there are some myths out there that people hold on to about pain management methods. As we said earlier, only 31.5% of respondents disagreed or strongly disagreed with the statement that when you take pain medicine, your body becomes used to its effect and pretty soon it won't work anymore. So a third or so of our respondents obviously have concerns about tolerance. And then also 29.5%, again almost a third, believe that most people taking pain medicines will become addicted over time, and 33% believe that people become addicted to pain easily. So not surprising perhaps, but tolerance and addiction are separate issues, but that is very conflated in the public mind. And then more than 4 in 10 respondents agreed or strongly agreed that it is important to take the lowest amount of pain medicine possible and save larger doses for later. 27% agreed or strongly agreed that pain medicine should only be taken when pain is severe. So these attitudes regarding pain management likely are contributing to inadequate pain care and disrupted treatment plans. If you're withholding the medicine and waiting till pain gets too severe, then it's often harder to manage once it's already reached a high threshold. So education focused particularly on dispelling these myths, and then also education that encourages development of patient advocacy, patients being self-advocates. Almost 1/4 of the respondents, 23% of the Task Force Healthcare Consumer Survey, who reported experiencing chronic pain, said that they did not feel like they were active participants in decision making about their treatment plans. Almost 1/3, 31%, were not able to respond affirmatively when asked if they had an adequate amount of time to think about the treatment plan that their healthcare provider recommended. 1/4 were not able to respond affirmatively when asked if they felt that they were able to refuse recommendations or ask for alternative treatment options. So they're basically almost around 1/3 and 1/4 in each of these questions of people who are experiencing chronic pain do not feel like they are contributing to the process of their treatment plan and helping to being active participants in creating their treatment plan, having any time to think about it before, or even asking for other recommendations on a treatment plan. And then respondents were also asked, respondents who said that they experienced chronic pain were asked if they keep a log or monitor their pain in any way, and 70.4% said that they don't monitor their pain or keep any sort of log that would then help be able to bring to their provider and say how the treatment is affecting their pain. And so just help figuring out what sort of public education we could create that will help people to become their own pain advocates. So the last thing is just to say that information that the public besides just being monitoring their own pain, certainly information out there about a full range of treatment options, strategies for monitoring and reporting pain, strategies for communicating, tips for communicating with their healthcare providers and setting treatment goals, and information about referral rights are all things that could be included in that building building advocates, pain advocates. So, opening it up for questions.
This isn't really a question, Lindsay, it's more a statement. I think we're going to hear a lot more tomorrow. It seems sort of overwhelming what you presented, but the reality is that a lot of what the recommendations that already exist in terms of what other places have done. Certainly we're going to hear from the Missouri Pain Initiative and how they tackled some of these issues. And we're not going to have to reinvent the wheel around a lot of these things. We've got it, and we just have to figure out how we're going to implement it. So.
I think that's a great point, looking around at states that have already worked on these certain advocacy questions or provider education questions, and using the models and tools they've created will really help us a lot. Anything else? I encourage you all to do take a look at both the white paper and that annotated survey in the back. And then also I think in the binder are all the policies. Did you have the printout from PPSG just in the binder?
Yeah, it is.
I just wanted to say I did a wonderful job writing it up.
Oh, thank you. Thank you. Well, thank you for all your work.
We are so lucky to have Lindsay as part of this process. She's just been an amazing resource, and quite honestly, I don't know if you guys are aware of this, but we have over 30 members of this task force from all different walks of life and different professions that are work in pain management, and so we're just really blessed to have so many people currently working on this issue. And tomorrow is the day that we get to talk about how more people can get involved with it, and kind of our vision of moving forward and trying to tackle some of